right. I think we're ready. Are we ready to call the meeting to order? I don't see anybody saying no, so I guess we'll go ahead and call the meeting to order today. Welcome everybody for our January Board of Health meeting, January 3rd, 2020. We'll go ahead and call roll, and we'll start with Commissioner Finney. Oh, okay, go ahead. Karen.
Karen Stratton, City of Spokane. Mary Cuney, Spokane County Commissioner.
Ben Wick from City of Spokane Valley.
Kevin Freeman, City of Millwood.
Michelle Fossum, Legal Counsel.
Betsy Wilkerson, City of Spokane.
Dr. Jason Kinley, appointed citizen.
Josh Kern, Spokane County Commissioner. Bob Lutz, Health Officer.
I'm Clark, Administrative Officer.
Welcome to our new members of the Board of Health today. So, Mr. Kinley, or Dr. Kinley, sorry, and Councilmember Wilkerson, welcome. Now we're up for citizen input. I have one member of the citizen that would like to talk today. Can we please have Lindsey Donahue? Oh, come on up to the podium, and there'll be a microphone there. And you'll be limited to 3 minutes, and we have our wonderful timer here, Mayor Freeman.
Okay. Hello, my name's Lindsey Donahue. I have an undergraduate degree in biological sciences from Cal Poly and a naturopathic doctorate from in Portland, Oregon. And I am concerned about the current deployment of 5G in Spokane County. I believe we have no reason to believe 5G is safe. Electromagnetic field impact, they do impact cellular health. Effects of microwave frequency, or EMF, produce a whole series of changes in the body, changes that have been reported in many different studies and have known mechanisms that explain the process. There are papers that discuss the issue of current health standards that are based on the assumption that all we have to do is worry about heating. Those are the standards the FCC uses. These standards have been contradicted by over 20,000 papers in scientific literature. The FCC radio frequency radiation limits are based on a 1980s research of behavioral changes in rats exposed to microwave radiation and were designed to protect from short-term heating risks due to radio frequency exposure. Since these guidelines were adopted, there have been peer-reviewed research of more than 500 studies that have found harmful biological effects from exposure to radio frequency radiation at intensities too low to cause significant heating. Despite all this scientific evidence, I'm worried that Spokane has decided to follow the FCC guidelines, which are poorly guided, which is putting health of plants, insects, animals, and humans at risk. Due to time limits, I'll give a single example. EMFs activate voltage-gated calcium channels in the cellular membrane. Through this mechanism alone, downstream effects are that of oxidative stress. Heating has nothing to do with the biological effects, and therefore the safety standard is based on a false assumption. The deployment of 5G should be delayed until we learn the extent of health risks. Thank you for your attention. Under 3 minutes, right? Okay.
Very good, thank you. All right. Having no other citizen input, we'll move down to the consent agenda. Is there anything on the consent agenda any member would like to set aside? Seeing none, do I have a motion to approve the consent agenda?
Second.
No.
Yes.
Moved and seconded. All those in favor, please signify by saying aye.
Aye.
All those opposed, same sign. Consent agenda is approved. Now going down to the 2020 meeting schedule. Assuming everybody got a chance to review the meeting schedule. We did take a look at the STA board meeting schedule as well, and we do not appear that there are going to be any conflicts this year. Knock on wood. Does everybody get a chance to see it there? Okay.
I move to adopt the 2020 meeting schedule.
All right. Do we have a second?
Second.
All right. Any further discussion on the meeting schedule for the year? All right. All those in favor, please signify by saying aye.
Aye.
Those opposed, same sign. Meeting schedule is approved. Looking forward to seeing everybody this year. Going down for Resolution 2001, adoption of the revised Board of Health Committee descriptions and operating guidelines. So this is a follow-up from last meeting where we talked about combining the education and policy committees. So this just kind of cleans up our language to implement what we discussed last month. I don't know if we have start off with a motion for that as well. We have a motion?
I move to adopt the revised Board of Health Committee descriptions and operating guidelines.
Do I have a second?
Second.
Thank you. Any further discussion on committees? All right, all those in favor, please signify by saying aye.
Aye.
Those opposed, same sign. It is approved. Thank you, everybody. And now for committee membership. Don't everybody jump at once, but we are looking to see who wants to be on the committees and serve on those for the year. How about the Budget and Finance Committee? We'll just kind of take it in order. I know, Mr. Hafner, you were on there before. Do you want to continue on the Budget and Finance Committee?
I will be more than happy to.
Commissioner? Is there anybody else? Yeah, I had him down as possibly for a chair. Is there anybody else that wants to be on the committee first?
Just budget and finance.
Yeah.
I will.
Oh. Okay, so 1, 2, 3, 4. I know we try to keep it to 5. Anybody else? Looks like there might be someone. Linda?
I couldn't hear you exactly what was said there.
So we're trying to keep committees to 5 if we can.
Okay.
So we're looking to see which 5 people would like to be on Budget and Finance.
Oh, budget and finance, okay.
And right now we have Mr. Hafner, Councilmember Stratton, Mayor Freeman, and Ms.
Andrea.
Frostad. Does that sound?
And I would like to be on that. Does that make 5 or 4?
Is that
1, 2, 3, 4, 5.
okay? Am I counting wrong? You're right. That would make 5 exactly. Does that sound good for everybody then? And then the chair of that committee, I know Mr. Hafner was talking about it. Is there anybody else
I'd like to chair the committee.
who'd like to chair the committee? You got,
But
you feel strong? Does either one of you feel strongly about it, or chairing versus not chairing? How do you want to?
One of the reasons I'd like to be invited to the chair is because I can follow the budget.
I'm good with that. I flew on a plane yesterday, so I'm not hearing very well, so takes me a day to recover from that. So I'm good. I'll withdraw my, if Mr. Hafner would like to chair that, I'm good with that.
Okay. So that fills out our Budget and Finance Committee. Policy and Education Committee. Right now, I don't have anybody listed on that committee. Or anybody want to be on that one? All right. So we have Councilmember Big. Yeah, no kidding, right? So those are taken. Yeah, no kidding. Everybody wants to be on committees this year. That's great. So we have those 5 over there. Does that sound good to everybody? And I think sounds good. All right. And for chair of that committee?
I was volunteering for it.
You're volunteering for it? Any other volunteers? Man, there's no volume nominations this year. That's good. Okay. So we have that committee set as well. And then for the chairs of the committees, you will be on the executive board. And I think that fills out the executive board, if I'm not mistaken. There's no other. There's one more for the executive committee. We have one position left on the executive committee. Is there somebody that wants?
How would that, what would that be?
I think
So-
the county is, I have 2 things on it, past chair,
Okay.
policy chair, but I don't know if we have, I don't know what the bylaws have. As long as all those people.
Okay. So then we're good then for the executive committee? We just passed the bylaws a second ago.
But, so are we short a person because you're holding two spaces, or?
We're not short a role, we might be short. If I wasn't holding 2 places, there would be another person on it, but I don't know how it's written. It's written by role or by number.
Who are the members of the committee right now?
So the executive committee would be myself as chair, Commissioner Cooney as vice chair, Councilmember Beggs as past chair, Mr. Hafner as budget and finance chair, and then we typically have the policy chair, which is now Councilmember Beggs.
So we have,
Or Council President.
so we have representation from Spokane County, Valley, appointed citizens. So if there is one vacancy, I would like to be on as the small city representative. If they're not small, if they're not wrapped up and we're full, then we're full, then that's fine.
And I'd like to be supportive of that. I think it's important when, rather than have somebody, I mean, I know you could talk from both perspectives, but I really think having more folks involved and at least every spot filled is a good thing. So I'd like to advocate for that, make a motion for that.
What's it say, Michelle?
So the bylaws provide that the executive committee consists of the board chair, vice chair, immediate past chair, and at least 2 other members appointed by the chair of the board, so long as we don't violate the board meeting.
Okay.
Awesome.
Well, then,
Point of, so Commissioner Kearns was just showing me what we just passed. It didn't have the 2 other people in it, in the language that we had, so.
I need the one that we just.
Well, these are the
Descriptions.
resolution number 20-01 that we just did. So it actually spells out that it's the chairs of the 2 committees, not just 2 other people. It actually spells them out being from those committees. But since Brian holds 2 of those positions, I mean, in the way you just read directly from the bylaws, I think we would be allowed to put Kevin on there because it just says 2 other individuals. So I think, and I have no problem with that. I think what Kevin stated makes sense, having somebody from the small cities to be on that.
Mr. Chair, I have no objection to that. We might have to, if we have to adjust language to make it happen,
Okay.
that's all I'm saying.
sounds good. We'll look at the language and see if we need to adjust it, because we should have everything saying the same thing in my mind. And so,
Right, I think we should adjust the bylaws then to match what we passed in 2001. I was reading from the bylaws.
sounds like that'll be a future action item for the board. Okay.
Who all,
Sure. So the executive committee is myself, Commissioner Cooney, Council President Beggs, Citizen Mr. Hafner, and then we will add, as long as I can, as chair, Mayor Freeman. Okay. All right. Now making it through that, we will go to the Resolution 2002 authorizing adoption of a revised Spokane Regional Health District procurement policy. Do we have a motion to start off the dialogue with today?
So moved.
Second.
All right. Mike, did you want to give us a?
I can just give you a brief update, yes.
Please.
This is a Resolution 20-02, looking for a revised procurement policy. We actually started working on procurement policies a couple years ago with the Budget and Finance Committee. We had made some minor changes from the way we previously did it, and it actually implemented some of those changes. But with the auditors coming in last year, they wanted to see that it was a board-approved procurement policy that we were following. And so I worked with this last year's Budget and Finance Committee on getting started on that. Also, as our new administrative officer, Ms. Clark, came in and started working with us, she read through it and had some suggestions and some changes. We also worked tightly with our purchasing coordinators in the building, as well as our management team. And so we think we've come up with a very much, it's sort of aligned with the county as far as thresholds and how we do our purchasing, but we've also built in some other items, such as at all the levels, you should be checking the state contract first. And so the Washington State Master Contract, we're allowed to use that as a health district. And because it's already went, a lot of the stuff's already been pre-put through the competitive part, we can go out there and check there first. And so we've come up with a very understandable, quick policy. We have procedures to back it up. We've also built a communication and change plan for our staff to understand it, and it's going to be much simpler for all. We had it pretty convoluted in the last one, and so I'm looking forward for a passage of the policy, unless there's some questions I can answer on it.
Sure.
I'm just going to make a statement because I was on the Finance Committee when we started looking at this, and so part of it was to look at the federal guidelines as well, and that's what the county did when we passed our procurement policy, was looking at the federal guidelines. And since so much of the funding comes from federal grants, it's important to match up with that. And so that's why I think it's important to take care of the procurement policy in the way that you have. Thank you.
Yep, thank you.
Any other questions or discussion on the procurement policy? Were you able to figure out the small works roster, if we're going to do that internally or the MRSC?
The MRSC, yes. I called them on the phone, and they put on there that we were going to do our own internal or do MRSC. But since that time, I've contacted them, and they are very much willing to let us join on to the MRSC small works roster.
Perfect. Thank you.
Yes, thank you.
All right. Last chance for discussion. Seeing none, all those in favor of the said motion, please signify by saying aye.
Aye.
All those opposed, same sign. Motion is approved.
Thank you.
Now I have a procurement policy. Moving down to reports. So we'll start off with the chair's report. Making sure that I don't do something. So just wanted to recognize outgoing Board of Health member, Councilmember Kate Burke. And she's unable to attend the meeting today, but she has served on the Board of Health from January 2018 through the end of 2019. And in recognition of her service to the district, we're going to donate $50 to the charity of her choice, which is the Martin Luther King Family Center. So thank you, Councilmember Burke, for your involvement in the health district. And also wanted to recognize Community and Family Services Director Sheila. Sheila is going to be retiring on February 18th. She's served in the Greater Spokane community as a nurse, executive, and public health leader. The Regional Health District has been fortunate to have Sheila spend the last 5 years leading the Community and Family Services Division. Under Sheila's leadership, CFS, and especially the Nurse-Family Partnership have grown immensely. So thank you for your service, Sheila. And I think that is all that I had for the chair's report today. Moving down for the Board of Health committees. I don't believe we had any committees meet since how we just appointed our committees for the year. Administrative Officer.
Oh. Well, of course it worked for the IS person. Oh, okay, thank you. Hi, welcome to our new members. I usually take this time in my administrative officer report to just kind of give some general updates, and then I like to provide some program information as well and some success stories. So, for our new members, I am new to Spokane. I've only been here about 4 months in this role, so I'm still continuing to develop my work plan, but I hope that you're all already starting to see some of our increased efficiencies related to the calendar, the procurement policy, and some stuff we've been able to kind of streamline since I've been here in just for a few months. So one thing that comes up a lot in committee meetings and board meetings is that we talk a lot about individuals experiencing homelessness and what kind of impact that has on the Spokane community. And following conversations that I've had with many of you and have had in the community, came back and talked to staff about, we've got all these pieces and parts of programs, but how are they impacting the greater issue of homelessness? And so as we began having those conversations internally, and those are up there on the screen, we noticed that we have a lot of overlap in our programs, but we don't necessarily have a coordinated approach. So Lindia, working with our health officer, Dr. Lutz, put together a group that we're calling our street outreach group, and looking at what we're doing out in the communities and how that's having an impact. So we're defining our street outreach, mobile, going in a van, car, bus, walking, backpacking, in the community to bring services and information where clients are. That's how we defined putting together our list of services, is how we're reaching people. And the importance of doing that is establishing those interpersonal connections, developing trusted relationships, and familiarity with clients. Sometimes, when you talk to someone the first time, you may not be able to immediately engage them in services, but after you reach out a couple of more times and they see that you're there and willing to help, they're a little more willing to engage. Our big focus through any efforts that we do is to really provide resources, access, and try to figure out where we can remove barriers for individuals receiving services. We already know that there are a lot of ways for individuals to access programs throughout the community, but are there ways for them to access them? Is there a transportation issue? Is there something that keeps them from getting that? And also looking at harm reduction. So again, like I was just saying, we're really looking at how are we meeting those needs, getting out there with providing consistency, building relationships, and using our current program infrastructure to greater reach individuals, not having to recreate the wheel or do something that someone else is in the community, but how can we make that better for the individual? Through bringing all of our staff together and having those discussions, we did identify some perceived gaps in services, with one of them being there's lots of behavioral health outreach, but maybe not necessarily a lot of physical health outreach. One thing we've noticed in our syringe exchange program, for example, is some needs for wound care and different things that we think could have an overall physical health impact on individuals. Dental services are critical but very hard to access if you're homeless. And again, that whole need for coordination of services and transportation. So our next steps is that we are actually going to hire a position, and I've already met with the executive committee about that because I can do it in line with our current budget, and include it into our programming staff to basically be that outreach person. For example, I was invited to a meeting at Better Health Together last week to talk about options and opportunity for the community, and that group included Empire Health, SNAP, the Housing Authority, and Volunteers of America. And so we really want to figure out how we bring the health district services alongside those groups and help make it help hopefully take all of the efforts forward to help individuals. And figuring out if, it makes sense for the health district to act as a liaison between different departments and community partners, because, we don't always say it, but even though nonprofits are very community minded, they're still competitive. And can the health district be the neutral ground that we can come together and just talk about what's best for the community and then figure out which groups work from there? And so I thought, because it's kind of vague when you're not working in programs every day or seeing the impact that what we do on the health district has on homelessness, I want to read to you a success story about a woman that Sheila's program, CFS, and the Nurse Family Partnership have worked with, and I think that will give you a really great example of how we're helping individuals. And my disclaimer, all names and references change, de-identified people, so I'm not sharing any PHI with you. So Sherry enrolled in Nurse Family Partnership shortly after her release from jail after a drug-related charge. She stated she had a history of meth use and had been clean for almost 2.5 years, and 2 of those years had been during jail time. She'd been living in supportive housing and participating in outpatient treatment, but was recently asked to leave the program housing due to a violent interaction with another resident. At the time of enrollment in Nurse Family Partnership, she was sleeping on a friend's couch. Her Nurse Family Partnership nurse provided her with a variety of housing resources and basic education on the discomforts of pregnancy that she was experiencing. She encouraged Sherry to decrease her use of cigarettes and referred Sherry for possible enrollment in TANF. Sherry had a very difficult time staying focused, and program content was altered to deliver that into small segments so that she could keep working through all of her prenatal work. And much of the time, the nurse spent dealing with the crisis of the day. Very early in pregnancy, Sherry had already started to show signs of early attachment to her baby and would be warm and soft and all the things that you want to see a young mother starting to do. Sherry continued to see the father of the baby, but there were some issues that caused her a lot of upset, and there was an issue of family violence when Sherry also ended up contracting an STI. During her second trimester, when the nurse-family partnership nurse met with Sherry, she was covered in bruises. She reported that the father had beat her twice while he was using meth. She still continued to deny use herself, and after being beaten, NFP helped get her to the hospital for seizures and bleeding. She could verbalize how unsafe her relationship was with the father of the child, but had no skills or ways to get out of the situation. A week later, desperate to get out of that situation, she moved in with both of her parents. Both of her parents are active meth users. She reported to her nurse that she had a relapse while staying with her parents, but she was dedicated to being a good mother to her baby, and what help could we get her to? The nurse helped her get enrolled in a long-term inpatient treatment program for her substance use issues. That the program would actually allow her to keep the baby with her after delivery so that she could continue to bond with the baby and develop those important attachments. She established a goal of completing treatment, delivering a healthy baby, and if her probation officer would approve it, she wanted to move out of Spokane because she knew she had an uncle in Oregon who could help her. So Sherry continued to meet with her nurse throughout the pregnancy. Her baby was born at 39 weeks, weighing 6 pounds and 14 ounces. So overall, a good delivery. After just discharge from the treatment facility, the baby did have to be readmitted to the NICU for 3 days due to some feeding issues and congestion. And, you know, NFP nurses continued to work with mom up to 2 years post-delivery. And so they were able to stay in contact with Sherry through this whole program, through her whole pregnancy, work with her through the stresses of having a child in the NICU. And while they were working with her, again, continued to complete assessments, and they did note that she was developing depression and anxiety and most likely postpartum depression. They immediately were able to get her into a physician who confirmed that diagnosis and helped her receive treatment for that. So Sherry continues to remain receptive to the parenting and education and has just demonstrated a strong maternal bond with her infant, which is what you want to see. All of her issues right now, like with CPS and probation, that has all been closed because through our help and staying with her, she's complied with all of the requirements of that program. She completed her substance abuse treatment program. She was released back into the Spokane community. And after several weeks, while staying sober with an infant and a friend, she was able to get help to move to Oregon to be with her uncle. And we were able internally to help transfer her to an NFP program that's in Oregon so that that continuity of care continues. So, you know, this is a great story, right? I mean, Sherry met all of the things that you want someone to meet to become self-sufficient and work through those issues that she was facing. And it was something I wanted to share with all of you because I think it's a great way to show how we're trying to not just deal with homelessness, but to prevent homelessness, because Sherry didn't have a lot of options in this situation, and it was a way to kind of keep that from happening. And as we continue to think about, as a health district, how we want to respond, we really want to continue to look at those upstream ways and how getting to someone before they're homeless can be a big part of addressing the issue. So, and with that, I am done. I can answer questions.
Thank you. Any question?
I just wanted to thumbs up on the approach and the strategy, and I note on the Today we're recognizing Kate Burke. She's not here to see it and hear it. She'd be very happy.
So I just wanted to say the same thing. Thank you for defining the role of the regional health district in this homelessness and how you put that together. And I think that really helps put things in perspective. And also like being the liaison with these other partners and kind of maybe leveraging that so there's more of a direction going in the same way instead of, so I appreciate what you just presented.
Thank you. Yeah, I think that the conversations that I had last week with the community partners are going to continue to grow, and we'll just keep kind of building from that and figure out how we fit in with those different things. And I think leveraging is a good way we do that. Thank you.
I think this is an indicator of what the health district can do and does do. And again, we don't blow our horn enough with our people and exactly the expertise that they have. And so thank you for doing that, Amelia. And I think all of us sitting at this table should be able to explore more and more of the things we do and let the community know that Spokane Regional Health District is here.
Mr. Kinley?
A couple questions. First, the competitive nature of the programs, are those due to grants? Is that what they're trying to get at this point? Is that what you mean when you said some of the nonprofits are competitive?
Yeah, sometimes they're competitive. And, one thing we talked about at that meeting last week that I had over at Better Health Together's offices is, like engaging federally qualified health centers is a great way to engage folks, to deal, because that's your safety net plan in terms of primary care. But you also have to kind of balance that if you have two federally qualified health centers who rely on Medicaid payments and HRSA grants to stay viable, one might want to overstep the other to get more of those patients. So, figuring out how they'll work together as part of their strategy to get everybody served.
So what about looking at local providers that don't use those programs and figuring out how to do a tax break? So for example, I have a free low-income clinic that I do once a month. I don't get anything for doing it, but the number of providers who are stepping out of larger practices is increasing because they're trying to get away from insurance-based models, so they no longer qualify for Medicare, Medicaid. So figuring out a way to support them locally from the business perspective may actually open up the provider window if we can use the health department to try to go back to the local cities and figure out a way, either reduce B&O taxes or give some kind of a credit for providing those services where they're not making anything. So now you've just opened up the door to for-profit centers trying to increase access to care.
Yeah, I would have to defer that to other board members. I don't, I can only speak to, what a federally qualified health center does as that example, but that's not something I can speak to.
I'll just say, coming out of the nonprofit world, there has been chatter about someone really taking the lead on this, but none of them have the capacity to do it. So it has been a wish for a long time of coordinating services, and that would probably minimize some of that resource deficiencies because there's so much overlapping and help them clarify their roles and the part they play in this bigger picture. So I applaud the health district for doing that.
Thank you.
Is that position for the physician, is that a full-time position or a part-time?
It will be full-time.
It's full-time.
Just go ahead.
And then yesterday, when we were over in Olympia for Association of Washington Cities Days, we ran into the Group Health Foundation person who was just new and being introduced around. And as we were having lunch, we talked. And one of their priorities is dental. So as you're talking about grants and options, coming together and coordinating an effort to not everybody applying for the funds, because having worked in nonprofit as well, it's like, how do we come together and get a bigger amount of money for our region? So we'll make that connection. He had no cards. He's pretty new, so we'll get his card. And
yeah, and I think they've already maybe reached out to us because
Perfect.
we do have the ABCD ABC Dental, a lot of acronyms here, program, and they work with the Arcora Foundation as well. And our staff, we have someone dedicated to the oral health program, and she's providing some additional testimony and information for them for over in Olympia next week.
They did give out a lot of grants in the last month, but then he said we have small grants, 5 to 10,000, which isn't small to me, but
Yep.
in the nonprofit world. But that maybe could be for planning, for the group to come together, do something. Yeah, good.
Great idea.
I will just add that I think this is a perfect time also.
On? Is it on? Okay. This is a perfect time, as we talk about these issues, to remember that we have a medical school in Spokane, we have the University of Washington doing dental, we have dental students in Spokane, and how we can partner with those institutions that have students that need experience. To me, it's, if we don't make that connection with the hospitals as well, but those universities, because there are so many different programs that we can access with students who need that on-the-job experience or that practical experience, that we really need to connect with them.
Okay, Commissioner Cooney?
Awesome. So I just want to say thank you very much, because I think it's really important. And do you know then when you anticipate to have this person on board?
Well, I just wrote the position description. Flying, building the plane while I fly. And I think that we'll have that posted within the next few weeks and get that out.
No, that's great. Thank you.
It's just as a reminder for those of us that may not remember / are new guests, we have 6 microphones that can be on at any one time. So if we're not speaking, we have to turn them off so that way other people can turn on their microphones. So it's a great tool, and also just to be mindful of the limitations of technology sometimes. All right, now we'll go on to the health officer.
Well, good afternoon, and as did Amelia, I'd like to extend my welcome to our new members, Councilwoman Wilkerson and Dr. Lindley. Thank you for being on board. Looking forward to working with you. In contrast to the positive, upbeat story that Amelia left you with, I don't want to bring you down, but this is also sort of what we're dealing with in Spokane. And I also do want to make one more sort of ad lib comment. Heather Gallagher, who Amelia referenced, who is our oral health person, is sitting in the back row. I've had the chance to work with over the last couple of months, and just an incredible resource. As Amelia mentioned, accessing dental services, especially for Medicaid individuals, is near impossible. And she has networked incredibly well, getting people in. I saw a patient, for example, in urgent care a couple of months ago. I contacted Heather. I saw her for a dental abscess. Heather had her in to see a doctor within a couple of days. So again, she's doing great work. And again, I think it speaks, as Chuck said earlier, that we've got great people doing a lot of great work. And the more people in the community know the great work that we're doing, I think the better they'll understand the work that we're doing.
Maybe she needs to stand and shake her head.
So, I'll be giving you an update on hepatitis A, respiratory illnesses, influenza, pertussis, and of course the sexy new respiratory illness called novel coronavirus 2019, and then some other stuff. I'm going the wrong way. There we go. So update on hepatitis. As you've heard from me the last couple of months, we've been impacted significantly locally by hepatitis A that has disproportionately affected individuals who are living homeless and or abusing substances. The thing that I want you to take note of is the epi curve on the right. And as I've mentioned in the past, a lot of credit for seeing a relative plateauing and then decrease in that epi curve really should be given to the outreach efforts of SRHD, which again I'll mention in the next slide. But that kind of gives you sort of a flavor of who unfortunately has been afflicted and affected by hepatitis A. And unfortunately, we've had 3 deaths. So we have the majority of individuals diagnosed with hepatitis A in the state, and we also unfortunately have the number of deaths in the state. So to address that, however, and these numbers are constantly changing, but imagine, if you will, that our team of immunization experts, and I see one of them in the back, Kylie, please wave your hand. Through her efforts and other outreach efforts, and again, partnering with a lot of organizations, MRC internally, we have a nurse in the TB program who's been working very closely with Kylie. More than 2,200 vaccines, okay, over the last couple of months. And that's, again, to almost 2,000 unique individuals. The thing that you have to recognize is that by giving a single vaccine to individuals who are at risk for hepatitis A, you are significantly impacting the likelihood that that individual will contract hepatitis A and therefore pass it on to somebody else. So again, I think, and I would offer to you, that the reason that this outbreak has been lessened to the degree that it has is because of the great work of the health department in really trying to prevent further cases from happening. So kudos again to Kylie, all the immunization folks, and just a lot of staff, time and effort to really address the epidemic, the outbreak. Respiratory, this is typically cold and flu season. It's also pertussis season. This kind of gives you a reflection of looking at pertussis over the last number of years. You can see that the last significant uptick in pertussis was back in 2012. Now, 2019, we're seeing another. It's interesting that pertussis tends to have these sort of cyclic variations. So every 3 to 5 years, every 5 to 7 years, you'll see an uptick in the number of individuals experiencing pertussis. As of 2 days ago, we had 46 new individuals in Spokane County who again had pertussis. This is just looking at rates. And again, you can see that significant uptick in 2012 and again going up to those numbers again in 2019. Most of these young people are indeed young, under the ages of 18. So more than 50% of these people afflicted have been under the age of 18. And you remember last month or 2 months ago when I sort of talked a little bit more about Bordetella pertussis. Very, very concerning, especially for infants. These are oftentimes the patients that end up hospitalized just because pertussis can be deadly to infants. And so again, I think great work by Lydia's shop and all the epidemiologists. It's been, regular calls working with providers, helping them understand what to do. We talk about prophylaxis. We talk about prophylaxing the family. So if you have a child who has been, or a family member who has been identified as having pertussis, the likelihood of you coming down with pertussis is about 80%. And even though we have a vaccine for it, we know that the vaccine efficacy tends to wane with time, and therefore it's essential that we get out and get these individuals treated quickly. And the reality is that unfortunately, the first couple of days of pertussis looks like a cold. So again, it's going to be not something that you as a provider are necessarily going to think first, second, and third about. Again, I think credit to the agency, we have done a number of provider alerts. And I would suggest to you that because of the provider alerts, we've raised awareness, and so now people are testing for it. We're able to identify it more quickly, and therefore get families treated more appropriately. So. And this again, just is another different type of curve, but again, just demonstrating, again, pertussis and looking at probable cases versus confirmed cases. Flu, it's flu season, as everybody knows. Flu tends to be underreported, it's not as much concerning, and as I mentioned, it's not quite as sexy as a novel coronavirus. But the reality is that it is a significant illness, and unfortunately, we still know that a large percentage of individuals go unvaccinated. If you look at the numbers so far, there have been 15 million flu illnesses across the country. There have been 140,000 hospitalizations and 8,200 deaths. Now compare that to the novel coronavirus, for which we have 170 deaths confirmed. Now granted, those numbers are going to go up, but I've got 8,200 deaths in this country already due to flu. The thing that's interesting about this year's flu is that whereas typically we see mostly flu A early and then flu B later, this time it's just the opposite. So we're seeing more flu B earlier on. And unfortunately, the vaccine is good, but we're concerned about kids because we're seeing a large number of pediatric deaths due to flu this year, more than we typically see. And that's not uncommon when flu B is the predominant species or predominant strain of flu. So again, I don't want to emphasize this novel coronavirus, but again, the reality is that flu we deal with on a yearly basis, and it kills people, and we have a prevention for flu, and we're not taking as good advantage of it as we could or should. Again, you'll notice our curve, and the reason I would suggest to you that to some degree you look at that big peak, which was a couple of years ago, versus the red, which is this year, we're seeing a lot of outpatient visits, but not as many hospitalizations, which is what this curve reflects. So the numbers are still significant. We are still going to see a significant number of people nationwide and locally with flu, but we're not seeing the number of hospitalizations because, again, it's affecting a younger population, kids, but also younger people who do not have the other illnesses that make them more susceptible. And that, again, another CDC curve, just again demonstrating the purple is influenza B and the green is influenza A. Coronavirus, you've all heard about it. It's fascinating. This is in the same line of viruses as the SARS virus from early 2000s, from MERS, Middle Eastern Respiratory Syndrome of a couple years ago that's still sort of bubbling across primarily the Middle East. But again, this is a coronavirus. As you all know, it is presumed to have started in a live animal market where they provided wild animals. Interestingly enough, coronaviruses have been identified in bats historically. And so there is some research that suggests that this isn't so novel. This actual virus was identified a couple of years ago in some bats in caves in China. Unfortunately, bats are consumed in China in these wild markets. And when you put a lot of wild animals together in very close contained spaces and environments with humans, it's not uncommon, unfortunately, to have these zoonoses, i.e. animal-derived illnesses, pass over to humans. And so that's what's happened. Some of the genetic testing has suggested this may be coming from a snake. Not sure. But irrespective, I mean, it started in a wildlife market, and now we see that, close to 8,000 people across China have been diagnosed. About almost 200 people have died across China, and obviously those numbers are going up. It's also in the United States. You may have seen in the news today that today was the first person-to-person transmission in Chicago. So there was an adult who had been diagnosed who passed it to his or her spouse. And so that's the first person-to-person transmission. We expect to see more of that. And again, I think that we expect to see more of that internationally. So it's across many countries, and you've seen the bans and the quarantines. Imagine, if you will, quarantining 51 million people. I can't even begin to imagine what that would look like, but that's what's been attempted. And for good or for bad, it's essentially some effort to try to contain this virus. The challenges are we don't know about it. We don't know a whole lot about it. And so it's novel, yes, it's novel, and so we're learning more about it. And until we know more about it, we're going to be struggling with how best to protect and prevent people from coming down with it. So what you'll find is that there have been a lot of preventive recommendations, DOH, Department of Health, the CDC. We've had a lot of calls on a regular basis. Lydia's team and Susan's team have been on calls almost on a daily basis, working with experts to really translate that information to the community to figure out what do we do about this. So how do we protect individuals? Every person who has been to China, or every person who knows somebody who's been to China, or where do you go? Where do you stop? Because you can see sort of the exponential curve, how this would get really kind of out of control. So we also today activated what's called our incident command system to kind of manage this and coordinate all of our internal efforts. So stay tuned. But again, I think, the next couple of weeks will be very interesting to see as we learn more about this. Again, we don't know just how contagious this is, and although we know the means of transmission, we just don't know whether or not it's easy to transmit it. And we also don't know its virulence. So again, we have 8,000 individuals, 170 deaths. That's nothing compared to what we saw with MERS or SARS, but that's also what's been reported to date. And so we really don't know.
Is there a treatment? Suppose I come down with it, how do you
Support you? Again, I think that's a great question. The reality is that it's a cold virus of sorts. But we know that cold viruses, especially these types of viruses, can progress on to pneumonia. And so it's very much supportive. And to date, the majority of individuals, with one exception that I've read, have been individuals with other medical issues. And so obviously, if you have heart disease or lung disease or any of those other illnesses that predispose you to coming down with a worsening of a respiratory infection, then that's possible. But there's no antiviral treatment. They're talking about, rushing a vaccine, fast-tracking a vaccine. Everything is sort of in evolution right now. But if you were to come down with it and be diagnosed with it, then again, the treatment is really supportive at this point. Questions? Oh, I forgot. Just real quickly, I forgot my other. My two others are, as you may remember, a couple of months ago, I talked about our creation of a health advisory council. We've been meeting, and what we're doing this year is, the first year was really kind of introducing members to what the health department does. This next year is really going to be asking individuals on that council, what do you do about specific issues? And then that specific issue, what do you think the health department should be doing about it? Timely, the first meeting, we talked about homelessness and some of the ways that the health district can approach homelessness. What Amelia talked about are some of those recommendations. They talked about the importance of using data, which, as you know, is sort of one of the key things that we do here. The importance of, if you will, changing the narrative, changing the understanding of what homelessness is and who is homeless. Again, there is this constant image of those individuals who are living chronically homeless as the face of homelessness, and we know that that's but a small percentage of the total number of individuals who are living or experiencing homelessness or getting close. They also talked about outreach efforts, which again Amelia talked about, and so it was really encouraging for me to hear from experts and from voices in the community that these are the things that they also believe that we should be doing. And then finally, we've talked a little bit about it, but we formed an ethics committee. This past month, we had our first meeting. I was very happy to see Board Member Frostad on board. And what we're doing is essentially introducing the agency, how we approach the work that we do from a public health ethics framework. And we're fortunate enough to work with a philosophy teacher who's an ethicist at Gonzaga University. And we're also working with a lawyer, MD, who are providing those two key areas of expertise to our work. The idea is that we're going to be looking at some of those more controversial topics over the next year and coming up with you, Will, as sort of like white papers or policies on how we're going to approach a specific issue, be it homelessness, be it vaccines, be it what have you. And then use that as a framework that when we're wrestling with some of the challenges that come across us on a regular basis, we have that framework to fall back on. Those are my others. Anything else? Questions? Yes.
Who's on that advisory board?
I had that list. Remember, I presented that list last year. Off the top of my head, yeah, I mean, we talked about it here as an advisory council, so I have representation from Providence. I have representation from the Native Project. Let's see. University, WSU, we have Albert Tripp representing Airway Heights. I remember last year we had him inappropriately labeled as a government, or I think as an elected official versus a government recommendation. We have somebody from Kaiser. I have somebody from Frontier. I'm just going around the table and seeing. We have somebody from law enforcement. We have somebody from K-12, public ed. Again, the idea was really trying to look at different sectors. I have Mark Richard, for example, representing the business community. And so we have people from different sectors trying to give different perspectives on issues which, again, they may be dealing with from a public health standpoint. I can get that list, though, and again, recirculate it. Certainly.
So is that advisory committee, I remember you talking about this last year, and then we saw who was on that list. So are these groups, are they going to alternate with different groups, and you're going to pick different groups, and then is it like open-ended, or is there like the questions that are asked, are they all open-ended and we're just gathering information from them to help?
So the idea is that when an individual comes on board, he or she sort of commits, if you will, in quotations, to about a 2-year commitment to it. And ideally, as it gets moving along, we'll be able to stagger those people coming on and stepping off. So I don't have everybody stepping off at 2 years in one fell swoop. It's very open. We looked at different sectors, but again, I think the way it's constructed is very open to different voices representing different areas of expertise across the community. And then with respect to topics, I thought, given the importance of homelessness as an agency and as a community, it seemed like a very appropriate first topic. But I don't necessarily have a list, unlike what we have right now forwarded as an educational outline or topics for board members. We haven't yet come to that. And so I would suggest to you right now it's somewhat fluid. If there are, again, if there are topics which the board thinks you would like to have this group sort of wrestle with and make recommendations, it's an advisory council to me and to the agency overall.
So back to the ethics committee that just met, I think that's great that that's happening here. But was there a hiring committee for those 2 individuals that are helping with the ethics committee?
Well, they're not really hired. I mean,
Are they volunteers?
They're volunteers.
Okay, awesome.
They're volunteers, yeah. And,
Okay.
and literally, Andrea, these are 2 people who I met. I serve on the IRB at Gonzaga. And so one of my colleagues is in the philosophy department. And I asked him, do you know anybody who works in the field of ethics? Well, yes, I do. I actually know somebody who's really interested, does bioethics. And bioethics and public health ethics, similar but different. And so when I presented the idea to Maria, who, as I mentioned, is the Gonzaga professor, she was really intrigued by the idea because it's sort of a variation on a theme of bioethics. Dr. Pam Kohlmeyer, she is an emergency room physician by training. She went back and got her JD. She wears many hats. She's also in Eastern Washington as an MPH professor. And so given the fact that she's a physician and also a lawyer, I felt that she provided unique expertise in providing us with some of that sort of legal issues that come up in public health ethics.
Okay. So at the end, if I heard it right, there's going to be a board that is selected of 4 individuals that will oversee issues that happen within the agency, that if there's an issue, it will go to this board if it's an ethics issue. Is that what I heard right? And it was you, and was it these 2 individuals?
Yeah, so it's, okay.
And then a 4th person possibly, if within that committee, that those volunteers within the health district that are going to be finishing the committee.
And I can certainly send the bylaws around for review. Essentially, the structure of the committee is that we have members from across the agency. And then right now, we're meeting on a monthly basis with the idea being that we're going to be going through different issues and coming up with these, if you will, white papers. That said, there are going to be ethical issues that are going to come up on a more regular basis than monthly. And so rather than calling the whole committee together to meet, there's going to be sort of a central group, sort of an executive team, that will then decide, well, this is something that is very germane. We need to address it sooner than later. We need to call the committee together sooner than later. Or, no, this can be tabled. Or, no, this really doesn't go the direction of public health ethics. It may be sort of a personnel issue, which we don't want to be addressing. And so that sort of core group consists of Ashley Beck, myself, Carrie, who's sort of our meeting coordinator and facilitator, and then one other person who will be a chair of the committee, and that person is still to be determined.
Okay. And then everybody who has questions about the class, they're to go through the Spokane Regional Health District employee.
So what I suggested, so as I mentioned earlier, Maria Howard is a GU professor. Her class schedule is kind of what you would expect a university professor to be like. And so if there are issues that, again, you, for example, really have an issue or question that you want to ask Maria, by all means, feel free. And I talked with her yesterday about this. If, however, it's relevant to the committee itself, its structure, what we're doing, things of that sort, then Carrie is the point person. And so we're trying to, again, limit the amount of extra emails going to a university professor. But certainly if there's a question that comes up that, you really want to ask her, again, she's very open to being emailed, and we'll provide that email and also another email going out this week to explain that very question.
Any other questions for Dr. Lutz? Thank you.
Too long.
Oh.
Mr. Chair, I do have a question. So this is an advisory committee to you as our health officer. Is that right? It's an advisory committee to you as a health officer that then would bring things back to this board for if there's any positions put out there or projects started or?
So again, what I attempted to do when I formed this last year was to look at different individuals. I mean, honestly, these are people that I had either met over the years of living in Spokane,
Yeah.
and or recommended to me, who maybe had unique perspectives, and or I really wanted that perspective from a public health lens. What does that look like to you?
Yeah.
So yes, they're advising me and the agency. They're not advising the board per se.
Okay.
So I certainly, however, for example, here's a wonderful case in point. Here I'm hearing from our advisory council that, I put homelessness out there as a topic of conversation, and they think that, using data, coordinating, education, those are the things that we think the health department should give consideration to in addressing homelessness. I bring those comments back to the group. I presented the idea back to ELT. And again, I don't want to say that because of that, we came up with this position description. The reality is that we've been sort of discussing this for a while. But I would suggest to you that this is serving the agency, and ultimately the board and the community as with another voice, so that I'm hearing from individuals who are in the field, in different areas, who can give me some thoughts as to how this topic may be relevant to them and affecting either their constituents or the people they work with.
And I think I understand how it came about. I'm just thinking of Amelia's role. Is this like a parallel? I'm sorry, I must not be tracking well. This is like a parallel group for advising you and the ELT, which is the executive leadership team. Is that right?
Yes, ma'am.
ELT, okay. All right. It sounds fascinating. I'm glad that Andrea was able to go
Well,
to one
different.
of the meetings.
Two different things.
Two different.
Oh, that's
That's an
different
ethics
thing?
committee.
Yeah.
Well, that's the ethics committee.
That's the ethics committee, public health ethics. This is an advisory council.
Okay.
So there's a health advisory council that he started last year to get input from all these independent groups for feedback. And then the ethics committee is a different
Okay.
issue.
Okay.
Mr. Hafner first.
If I recall correctly, I believe that the board approved the original advisory committee makeup and the composition, but those were perhaps refreshed or perhaps a copy of that provided.
Thank you. We did revise and update the bylaws as of our last meeting, and so I will make sure that the board gets those.
Right? Councilor.
I was just going to say, an example at the city is the police chief has his own advisory committee that he picks the people, they do it. Doesn't impact policy or laws of the city council or anything. It's just people to give him some broader community advice than his command staff. So it's just very informal.
And I think some of the confusion is ethics committee now versus
Yeah.
feedback committee. So I think that's where some of my
Council.
confusion comes in.
So I'm just back to the ethics committee. So I just have a question about this final four that's going to be overseeing ethical issues. within the health department. Does the board have any input on how that, who's part of that board or part of that group of those 4 individuals, or is it just one person?
So I'm going to let Amelia jump in here real quick.
It's really an operational thing that we need related to our accreditation with FAB, and it helps make sure that if there are questions or concerns that come up about a program, that we can look at it to make decisions. It's not a board committee, it's separate from the board. It's not one of the committees.
And I guess I would also just echo, it's not, I mean, I don't want you to think that 4 members of the agency are determining public health ethics for the entire agency. It's not like that. Rather, we're sort of serving as a filter. There's going to be a lot of things which, again, are going to come up. Is this an ethical question? Is this an ethical issue? Is this something that needs to go before the committee? Yes or no? And if there's any question, we're going to default to calling the committee together. But I also don't want to be calling the committee together every week, because I could see that potentially happening. And so the idea, and again, this is evolution. We will be seeing how this plays out. But right now, and this again is sort of guidance from colleagues across the state who have done similar, that you need to have sort of an executive team which does the initial vetting of the issue. And then based upon whether or not it rises to the level of calling the whole committee together, you call the whole committee together.
And I think to clarify, Bob, from what you just said, is that the individuals who are participating from outside are volunteers who have expertise in ethics. They're not employees of the agency.
All advice.
Correct.
So again, just to be clear, I have a health advisory council, all advisory. All advisory. Do not make policies, they make, hey, here's what we're thinking. What do you think about it? But it's advisory to me, the agency, for us to deal with. Then I have an ethics committee that is looking at creating an ethical framework, coming up with sort of, if you will, how do you approach this situation going forward when you are addressing it? So committee versus council.
All right.
Let's give a copy of our board members that was approved last year.
Okay. All right. Anything else separate from the committees for Dr. Litz today?
I've enjoyed being up here, don't get me wrong. And I can sing, but I don't think you want me to sing, but I will bring up Amber. Yes?
Well, thank you, Dr. Lutz. And then we
Pleasure.
have a legislative committee, but then we also have roles and responsibilities. Do you want to touch on anything for legislative, or should we do the financial real quick first?
I do have some legislative updates.
Okay.
I don't mind jumping up and then sitting back down and coming back.
Okay.
Helps me move my legs. I welcome, yes, same as everyone else, welcome to the new members. So excited to have you around the table and to see so many people here, and love your level of engagement today. For the new members, just a little bit of background on my role. I'm the health policy specialist here. My name's Amber Linhart. My report today will focus on state level legislation, but I work on a lot of things. I help support our program staff in interacting with policy. So if you've heard, Heather's been asked to provide testimony in Olympia. We have program staff working on policies with Spokane Public Schools. I have a project going now working out of the street outreach project that you heard about to try to work with Spokane Transit on ways to increase access to transportation for low-income folks in our community, just as an example of some of the things that I get to do here at the agency. But I just want to cover some very quick notes about state level legislation. I did make a trip out to Olympia earlier this week, and I'm going back next week. There's rumors floating around that more bills have been introduced this session than ever before, which is super cool since it's a short session and we don't have time to go through them all. You do have a number of things in your packets. I'm happy to answer questions. Next week, at the end of next week, is the first cutoff for bills to be out of policy committee of their house of origin. So the number of...
Just to jump in, so this is the highlights page, so everybody has, so this is what you're referencing right now. So if in your packet you had a little legislative highlights.
Yeah, and just to explain what that highlights sheet is about, is I'm actually tracking over 200 bills that are related to the legislative agenda, and it's not helpful for you to see all 200 of those bills. So I've pulled out the ones that seem to have the most momentum, that are moving through committees fastest, or that have a lot more support from WSELFO and our other partners, and highlighted here for you. So I'm going to go through the priority areas and just highlight a couple things. There are 2 recent bills that potentially address foundational public health services funding. What those would do is create a nonprofit health carrier community benefit fund. So health insurance carriers that have excessive surplus, they would have to pay up to 3% of that surplus into a community benefit fund. From that fund, some funds could be allocated for foundational public health services. Insurance carriers are not super excited about that one. They've been saying that they need that surplus for other purposes. Though these bills do seem to be getting a lot of traction and support, and a lot of people are very supportive of foundational public health services funding in the legislature, so I do expect to keep seeing those move along. In the second category, one of the bills here that's getting a lot of attention and has made some movement is Senate Bill 5395 here. And the reason that one is connected to preventing and reducing the impact of ACEs is that it would require comprehensive sexual health education starting in early grades. And in early grades, that would focus on how to recognize things like child abuse, affirmative consent, so the importance of getting consent from people, and behaviors that contribute to sexual violence. So that one has passed the Senate and is now in committee in the House. In substance misuse, everybody's talking about vaping. As a reminder, the State Board of Health passed that emergency rule banning flavored vapor products and vitamin E acetate. And so right now there's bills that have been dropped around nicotine vapor products, and other bills specific to THC vapor products are expected or may have been dropped today. Those bills do a lot of things right now that are probably not going to stay in the bills. I know people are talking about amendments, but they do ban flavors, require producers to disclose ingredients to the Department of Health, and they repeal state preemption, which is on our legislative agenda. Both of those bills, the House bill and the Senate bill, have health impact reviews that were completed by the State Board of Health review team, and those are available online. Access to care, just will highlight the Senate Bill 6128. That one has a lot of support and went to exec session earlier this week, and it would extend Apple Health coverage for 1 year post-pregnancy. Right now, women who are eligible can receive Medicaid coverage for up to 60 days after they have their baby, or after pregnancy has ended, and this would extend it to up to a year. And that one also has a health impact review that goes along with it. So those health impact reviews I'll actually talk a bit more about in my lobbying presentation, but they provide some pretty basic, understandable information about the potential health benefits and any risks and equity implications of bills, and those can be requested by state legislators. That's it for my legislative update, and I'm happy to answer any questions, or try anyway.
Questions?
I will yield to Mike.
I have a question.
Councilmember Thompson.
So I know you're watching a lot of bills, but one of the bills I have a question on is House Bill 2337, which requires a co-prescription of opioid overdose reversal medication with any opioid prescription. And I would like to know from our doctors in the room here what you think about that. It just seems like, as we look at opioid prevention and trying not to have people get addicted or misuse opioids, that we know the reversal medication does work, but it seems like it would increase cost, and it would, you'd have all this Narcan or whatever the prescription would be for, being given to someone who, maybe had surgery and has an opioid for, 2 weeks or something. There's a lot of work
So
going
is
on in the
that
legislature.
bill on your legislative highlights, or is that one you just?
I just had one I wanted to
Oh.
question about if the health districts.
That's the first I've heard of it. What I'll tell you is I don't like that idea. I'd have to read the bill to understand exactly what their goal is. I don't know if they're talking short term or if people with chronic pain. I just had a patient the other day that's on 4 a day, and he's prescribed 120 pills a month, and that's a standard prescription. VA combat vets, that's a normal thing that comes out of the VA. And so those patients, what they need, they don't need another prescription. They need support in terms of understanding that there's no judgment around the fact that you're taking them because he wants to get off but doesn't know how. So I think prescribing that medication increases the risk because he told me expressly he did take a month's worth in 2 weeks one time, and he was without it. So I feel like what we're going to do with that, from my perspective as a physician, is increase the risk that somebody's going to try to overdose or take a larger amount because now they got a backup in their pocket as a safety backup from the patient perspective. And I don't personally like that as a solution, but I can't comment on the bill specifically because I haven't seen it.
Okay.
And I would sort of echo, I don't know the bill, and so I can't likewise make any comment about it. I think you have to look at the individual, and I think there are risks and benefits to providing the medication to the individual and to the family member. So, for example, as of last year, based upon the governor's omnibus opioid bill, the state health officer has made available Narcan to anybody who wants to get the prescription filled under her license. And so you'll see, for example, downstairs in our syringe service program, we have copies of that prescription available to individuals because we want them to have it, not only for themselves and or for friends that they're unfortunately seeing overdose. So I think there are benefits, but again, I think that just saying, okay, fine, I've just prescribed you 20 hydrocodone tablets, and oh, by the way, you have to also have naloxone with it, doesn't make a whole lot of sense.
Right. I just brought it up because there's often drug companies that are sponsoring legislation that is, they say, are trying to help the opioid situation or something else. You know, we've seen that in the past, and I just wondered if you'd heard any of that in your work, Amber, if the, and could you tell us again what WASALFO is?
WASALFO is the Washington State Association of Local Public Health Officials. If you've heard of NACHO, they're like the Washington State NACHO. And it's the accrediting body.
Is that for
Yeah.
new people? We need to.
Well, and I know there's lots of different bills going through here. Maybe
Yeah.
we can get you guys to connect afterwards, because I know we have some members that have to leave at 2 o'clock again
I
today.
just thought,
Yeah,
With the
I haven't,
opioid
and I
work we're
haven't, I
doing
don't
here.
believe that one's made a lot of progress, but I'll keep an eye on it for you, Linda.
All right, thank you. Do we have a financial update for us?
Just quickly want to let you know that the exec committee of the board requested, and Amelia directed me to start doing financial reports each month, including updates on fiscal of where we're at for the year as it's going along. That being said, January is a real tough month to start on because we just started this budget at January 1st. We haven't completed this month yet. We haven't even turned in our time cards to have expenses spread out to any programs for now. As far as being able to bring you end of year 2019 numbers, we keep our books open for 45 days until February 15th. So if there's any appropriate expenses or appropriate revenues that come in that need to go back to that, we do that at that time. So what my commitment to you is in the packet that Ann or Carrie sends out, you will be getting, in February here, you'll be getting the end of year 2019 numbers as well as the January 2020 numbers. And then I will come to this meeting and bring those up and answer any questions, or we can have discussions on topics and that'll happen every month during the year that I'll be sending that out. So there isn't an actual finance presentation today, but there will be one each month going forward.
All right, we look forward to that.
All right.
Thank you.
Thank you.
All right, legislative lobbying roles and responsibilities.
Okay, I'll try to be fast since I know people have to go, but the most important information is on slides 3 and 4, so that should be good. what I'm going to talk about in this presentation is answer the question, can we lobby? Why or why not? How do we know if we're doing it? And what else can we do if not lobby? Caveat. I have an eclectic collection of degrees and certifications. None of them are in law. This is not legal advice. Michelle is here. If I say anything terribly wrong, just start flailing, okay? Second most important thing to remember. Can we lobby? No, we can't. There are things we can do though. So why can't we lobby? There's a few reasons. One is Spokane Regional Health District is a special purpose district. Special purpose districts can only lobby if they have an elected board, which doesn't mean a board comprised of elected officials, but that everyone is elected to the board. So we aren't able to lobby for that reason, and then also public funds can't be used for lobbying. So I think it's important to know what it is, so we can recognize it when we're doing it or when we are veering close. So how do we know if we're lobbying? It's just that. It's knowing what lobbying is and how it's defined at the state and federal levels. So at the state level, here's the definition of lobbying. I'll let you read it, and I'm going to break down the IRS definition pretty specifically. So we have to comply at the state and IRS level, federal level. So there's two types of lobbying, direct lobbying and grassroots lobbying. We can't do either of those. Direct lobbying is defined as communication directly with a legislator or their staff on specific legislation that reflects the organization's view of the legislation. So I'm going to break that down, unpack it a little bit. Communication directly with a legislator or staff can mean in person, face-to-face, in a formal setting or an informal setting. It could include letters, emails, or phone calls. Those are all types of communication, direct communication. Specific legislation includes bills that have been introduced, specific legislative proposals that haven't been introduced yet, but we know they're upcoming, and ballot measures. It does not include, this is important, regulatory actions, executive actions, school board decisions, zoning board decisions, corporate actions, or actions of an institution like a hospital or university. So there is still a lot of little p policy work that we can advocate on. And then reflecting the organization's view on the legislation, communication is rarely completely neutral. It seems unlikely that we would say anything about a specific piece of legislation and how it would affect us or our clients without somehow sharing our view. So it's best to just avoid it at all as possible. Grassroots lobbying is slightly different. It sounds pretty similar to direct lobbying, but it involves communication to the public, so not directly to a legislator, and that could be like a tweet, a letter, a poster, a public speech that is on specific legislation, so same rules as last time, that reflects the organization's view on the legislation and includes a call to action. So that means that it has something like contact your legislator, identifies a legislator to contact, provides contact information for a legislator, identifies a legislator as neutral or opposed to your position on legislation, or somehow implies a call to action. So what can we do then? First, the WACs clarify that the SRHD staff and board members can do really whatever you want on your own time and in your own capacity, as long as it's not using agency resources or time. And that a public office or agency can make an objective and fair presentation of facts relevant to a ballot proposition if that is normal or regular conduct of the agency. And it sounds like from our legal guidance that is likely not available to SRHD because it's not normal and regular conduct that's usually authorized by statutes. So we should just avoid it. But there is a lot we can do. There are some exceptions that the IRS makes to lobbying, and So these are great to know so we can know how to walk right up to that line without setting off any red flags. Subsequent use is the idea that we could, our data center could produce a report about violence in the community, for example, and then somebody might pick that report up and use that report for lobbying. That doesn't mean that we're lobbying, as long as we did a good job when we produced that report to disseminate it broadly to the public and not clearly connected to a bill or a piece of legislation. Nonpartisan analysis is a workaround. It's often analyses are not nonpartisan. Research is often subjective, but there are methods that can be used to analyze legislation, like health impact reviews that happen at the state level. I'll talk more about those in a second. And health impact assessments have sometimes been used to analyze bills in a nonpartisan way. And then lastly, as you've heard about how our wonderful staff, Heather, has been asked to come to Olympia, we're working on trying to get an invitation from a committee chair. If you get an invitation directly from a committee chair to ask you to testify, then you can speak to that legislation without lobbying, without breaking the lobbying rules anyway. So just some examples. I mentioned health impact assessment. We do have health impact assessment capacity here at SRHD. What a health impact assessment is in a nutshell for new folks, or if you haven't heard this spiel from me before, is that a health impact assessment looks at any upcoming decision. Could be legislation, could be budget, could be a local decision, an internal decision, and based on scientific evidence and community input, makes predictions about the health impacts of that decision, and then provides recommendations to maximize benefits and minimize harms. The Washington Board of Health has a research team that does health impact reviews. They're very similar to a health impact assessment, but they're very quick. They're basically a glorified literature review, a pretty systematic literature review with some stakeholder input. Those have to be requested by a state legislator, and they turn those around pretty fast in just a matter of weeks. They are different from a health impact assessment in that they do not provide recommendations for the decision makers, but the evidence so that decision makers can make their own choices. I think if there's a bill that you are particularly interested in, you can talk to a state legislator and encourage them to request a health impact review. Those are also all available on the Board of Health's website, or the State Department of Health's website. And then also, if there's a written request to testify, or a request for assistance, technical assistance, we can provide that as well. Clear as mud, right? Now I'm going to quiz you. You ready? Okay.
Just say no.
Yeah. Okay. An SRHD employee on the weekend doorbells and volunteers for a phone tree for a candidate in their personal capacity. Is this lobbying or not? No. You're right. Individuals have the right to express personal political views and participate in campaigns on their own time, or even take a vacation day and go to Olympia and on their own behalf talk to legislators. Okay, SRHD is invited to sign on to a letter encouraging legislators to adopt just cause protections for renters, and related legislation has been proposed at the state level. Cool, not cool? No, not cool. Yeah, it would be great, but letters are considered direct contact with legislators, and that's lobbying. Can't do that. You're doing good so far. Staff attend a forum with legislators on behalf of SRHD, and during a side conversation with a state representative, remind the elected official that a specific proposed bill would help SRHD clients. Lobbying or not lobbying? Can't do that. That's lobbying. Pretty clear. Yeah. Okay, another example. An SRHD program creates a web page listing policy solutions to address youth vaping, including banning flavored vapor products, and provides a link to a web form to contact a legislator. Can we do that? No. That call to action makes it grassroots lobbying. Okay, two more. SRHD staff meet with Spokane Public School Board members and ask the board to approve changes to school siting and redesign standards to support public health. Lobbying or not lobbying? That's okay. We can do that because school board decisions aren't legislative. That's one of those wonderful workarounds. And I'm doing this too, so I'm glad it's not lobbying. All right, SRHD staff, last one, are invited to participate on a committee drafting language for a bill that will be proposed during the upcoming legislative session. Lobbying or not lobbying? That one's tricky. It's complicated. I thought that was not lobbying. Michelle thought it was complicated. So my word of caution is just always check Board of Health members, SRHD staff. Always check with me. We can check with Michelle if it ever seems fuzzy. And that's all I've got for you.
I just want to say on that one, it seems like if you were helping draft language, that would be okay. But if they said, Spokane Regional Health District proposes this legislation, that would.
Yes, yeah. Mm-hmm. Mm-hmm.
It's critical sometimes to get the right words in there.
Yes, especially, well, some of the bills that are out there right now, there's one around changing, making milk or water or bubbly water the default beverage for children's meals in restaurants, which has implications for our environmental public health staff who go do restaurant inspections to monitor compliance. And so it is important to have the environmental public health people at the table to help understand the implications of those bills, yeah.
Okay.
Any questions? Thank
All right.
you.
I
Yeah,
just
yeah.
have a question.
Real quick.
Yeah, real quick. So the organizations and associations that we are members of, they are totally 100% allowed to lobby. So like if we belong to the Washington State Public Health Association, and the Spokane Regional Health District is one of the, there's not very many counties on there, but they're with Bezos and the Dairy Farmers Association. So they hire a lobbyist.
Yes, they do.
So, but their agenda, their legislative agenda is like different than the WASALFO.
It
So
is.
how does that work? And then on a state level, and because I know you're on the state board, that works a little different too, because I know the executive director can lobby, can go directly to a legislator and lobby for a proposal on legislation. So, but that's not at this level. But we can, these organizations that we are associated with, that's
Yeah.
how that happens.
Yeah, and between WASALFO and the Prevention Alliance and the Chronic Disease Leaders Council, whatever, there are, we are engaged with enough organizations that have contract lobbyists that our legislative agenda is covered. But I can let Bob speak to the State Board of Health.
Yeah, and I would just say that Michelle Davis, who is our executive director, she does not lobby. I mean, so we have things within the state board RCWs that we are directly responsible for. And so as those issues come up, she's talking with legislators relevant to those specific issues. Now, Jamie Bodden, who is the WASALFO executive director, as WASALFO, they have a lobbyist who again can lobby, and as you've seen, as Amber has mentioned to you, these are things which support public health. But again, Michelle does not lobby. Michelle provides recommendations and/or education to elected officials based upon issues that are germane to the state board's work.
Okay.
Okay, so on the Public Disclosure Commission, it does say that the term is actually used lobby for the director. And I don't know if there's some kind of whack for that just says, the executive director is okay, not, there's an exception for that rule. But they classify it under public disclosure as lobbying. Michelle Davis's role, she has lobbied, and there's a bill for it. So that's just, so there might be some whack in there.
Yeah,
but,
and I'll have to look into that further. Again, it was my understanding, based upon the work that she's been
Yeah.
doing, and again, the specific bills that she talks to electeds and that she testifies to, that she's either called or, again, she's representing the
hearings.
board for the work that we're called upon to do.
Okay.
And it may be that it's a 501c4
Yeah, it could be some
designation,
whack in
or,
there.
you know,
Yeah.
something.
But that's
It-
not for our level, it's just for that. Yeah.
Right, it's just like on here, on our legislative highlights, when Amber has supported by Healthy Gen, that is an organization that lobbies, and they do have everything in order to do that, and so they can find those small things, like, and also Washington Association for Substance Abuse and Violence Prevention, WASAP, we just worked on 2786, which establishes an opioid epidemic response advisory council with the purpose of preventing opioid addiction, and they had nobody from prevention in the bill. So we made sure that we added prevention to have the voices of prevention. And so by all of us working together with everybody we have who is there, and the medical societies on the Hill, I mean, everybody. So I think that's important to have, and they're all working with the groups so that we get the voices and find the voices who can speak up when agencies cannot.
Okay, so just
So my.
pulling it back to Spokane Regional Health District,
Yeah.
we don't do any of that.
We don't do any of
Right.
that.
And so just
We
kind
don't.
of clarifying that, here is
That's
the
right,
Regional
we don't
Health
do
Board,
anything.
we
So
don't.
the flip side of that is joining all these different organizations, and they have different agendas, and they're out there doing different things. How is our voice being heard? And then when you have these organizations who are making an ask of us to support a specific type of legislation, that they're lobbying us because they're actually doing the ask. So how do we protect ourselves from that type of lobbying? The opposite.
Amelia looks like she wants to answer this one.
We don't do it.
I think that would be through the Policy and Education Committee of the board, because
Okay.
they determine the legislative agenda that we bring to the board for approval.
Okay.
That would be how I would understand that.
It would just be through the board, but we can't do that, right? Because we can't
No,
lobby.
No,
but I'm
just
saying
talking
that the
about
committee,
different asks
yeah,
from
not
all these
asking.
associations and memberships that we're part of, they're asking our health department to do certain things. And so that's where it comes to the committee to discuss those.
All right,
Yeah.
Okay.
clear as mud.
So they're probably taking-
So,
will-
so
go ahead.
back to the ask real quick, the slide that you had is that you can do certain things, but the ultimate definement of lobbying is if you make an ask.
And if there's an ask and there's specific legislation. So for example, when I go next week to Olympia, I'm going with WSELFO. What I'm taking with me are nothing related to legislation, no bills. I'm bringing stories from our clients, stories from our staff, data.
All right, so next on our agenda is an executive session, and which we do need to do, so we will take about 10 minutes for pending and potential litigation, and we don't have to have a separate vote because it's already on our agenda. And so, and no action will be taken upon return to the open session. All right, I guess we'll go ahead and continue the meeting. And our next one is board member check-in. Why don't we start with Mr. Hafner today? Nothing. Dr. Kinley, nothing? Councilor Pertussis?
I just wanted to say I'm looking forward to a 2020 anniversary for the health district, and hopefully that's coming, because I've been telling everybody that.
Yes, in March, when Kelly presents, she's actually going to present to all of you our plans for Public Health Week, which happens in April, and we'll be celebrating the 50th anniversary.
Awesome.
The health district.
And then just wanted to say, we were, like I say, over in Olympia with Association of Washington Cities, and it was an awesome, awesome connection, and working with our legislators and being able to share good things. I did share I will have to say, we did share with one person. It wasn't a legislator, it was the person from the Group Health Foundation, our legislative agenda, because when people are asking about legislation, I can share about the health district. But those are great connections, and our legislators are very glad when we come from over there. So,
Councilmember Wilkerson? Yeah, looking forward to your service. Andrea?
Got nothing.
All right, I have none. Karen? Nothing. All right. And then, just as a reminder that our next Board of Health meeting is February 27th. Do I have a motion for adjournment?
I move to adjourn.
Second? All right, all those in favor, please signify by saying aye.
Aye.
All those opposed? We are adjourned at 2:23.